Good evening, everyone. My name is Jake Giesler. I'm an advisor here at TMFD Financial. Thank you for joining us for our Dental Academy webinar on risk managing your practice, presented by Dr. Lionel Lenkinski. I'll introduce Dr. Lenkinski here in a moment, but first I'd like to briefly introduce TMFD Financial and explain the valuable services we offer to our clients. Our goal is to make the financial lives of our dentists simpler by being a one-stop shop for all their accounting, financial planning, insurance, and consulting needs through one convenient point of contact. Additionally, we can coordinate with other professionals that you may need, such as lawyers, mortgage brokers, and bankers to ensure that all of your current and future needs are covered. In our experience, we found that providing these resources as a one-stop shop for financial solutions provides you with the comfort of knowing that all aspects of your financial well-being are synchronized. The result is simplicity, peace of mind, and confidence in your financial decisions. In addition, TMFD Dental Academy hosts webinars just like this one tonight to enhance both your clinical education and knowledge of wealth management. Please use the link that we will provide in the chat box to register for our mailing list so you don't miss the next presentation. And before we begin, I'd like to flip it over to my colleague, Aaron Carballo, who is managing the technology for us tonight to cover a few housekeeping items.
Thanks, Jake. For those unfamiliar with Zoom webinars, if you have any questions for Jake or Lionel, please utilize the Q&A button found at the bottom of the screen, and we will answer them at the very end. You will also find a chat button, which allows you to communicate with your panelists or anybody else attending this webinar. In regard to PACE CE credits, this will be sent out within the next 2 weeks. That's all on my end. Back to you, Jake.
Thanks, Aaron. I'm very excited to introduce our guest speaker for this evening. Dr. Lionel Lenkinski is a practicing endodontist, which is also the CEO of the Canadian Dental Protective Association, which is a mutual benefit association that provides risk management advice and legal assistance to dentists across Canada. He has been awarded numerous fellowship honors and awards for his contribution to the profession. He is a columnist and member of the editorial board of Ontario Dentist. Without further ado, I will turn things over to Dr. Lenkinski.
Thank you very much, Jake, for that introduction. I'm glad to participate in tonight's webinar, and I'm very honored that you selected me to speak. Before I share screens with you, I'm going to give you a couple of housekeeping items. Number one, the topic of risk management and regulatory compliance is inherently boring and could be the best cure of insomnia known to man. So I'm going to try and make it as interesting as we can. Secondly, I think we're going to hold questions until the end. There's also 4 sets of questions just to make sure that everybody still is alive and has a pulse during the meeting, and it kind of confirms attendance. So I'm going to share my screen with you right now, and we're going to get going. And hopefully just confirm that everybody can see my screen properly. Okay, good. So again, today's topic is risk management and regulatory compliance. It's kind of the lifeblood of one aspect of dentistry that's very poorly understood, not particularly valued until it becomes an issue. And the purpose of tonight's presentation is to give you an introduction and talk about the issues that come up. And there's 6 common issues we'll talk about that are in the learning objectives that you have in the program that I sent around and that publicized today's session. And we'll go over them in a moment. And I just want to give you my disclosure that I'm a private practicing endodontist, although part-time these days. And I'm the executive director, CEO, and program director of the Canadian Dental Protective Association, and I don't have any conflicts in presenting this. So let's dive into this. And it's important to understand what these terms are because people use them very loosely. Risk management is really identifying and prioritization of risks, and then looking at how do you mitigate this to minimize the damage and outcome of unfortunate events. Probably, and it's apropos that it's TMFD tonight, that one of the biggest risk management principles that there is on the planet is insurance, because, you know, the probability of having a fire in a dental office is very low, yet we all have fire insurance. Most of us have life insurance that, you know, ensures that our families receive some benefit after we die to pay estate taxes or create some wealth. However you look at this, it's all part of your planning. So that's really where this all comes from. And the early models of insurers started as mutual companies. So most of the companies that have the name mutual in their name were where the policy holders are the actual owners of the company through their policies, as opposed to a shareholder company where you can buy the shares or trade the shares or own the shares in the publicly traded markets. Typically, these were used for entities that were looking for some kind of risk management and insurance that couldn't get it in traditional means for a number of reasons that you know, we can go into later if somebody's interested, but it tends to be one of the oldest models. So when we look at the whole concept, there's a number of different steps that you really need to look at. The most important part is to look at and have awareness and have an assessment and prioritization as to what you're going to do, and to a certain degree transfer the risk to a third party through insurance, or, you know, being a member of a plan such as ours, that if you have problems, we tend to look after it for you. So that's risk management. The next extension of this is damage control, where, you know, if you do have an untoward event, you want to minimize the basically the any outcome that's negative to you, and limit what the damage could be to your reputation, to you financially, to your practice, to finances, and all the other things that come along. What you don't want to do is start getting into multiple areas where damage control has to come into effect. And I see this a lot with dentists when they run into problems with patients. They refuse to deal with it straight up. It turns from a disgruntled patient to a patient that leaves your practice to one that goes somewhere else, that may decide to sue you to recover damages or file a regulatory complaint. And once you get a regulatory complaint or are served with a notice of an intention for a lawsuit or a money demand for refund of fees, you're into damage control, and you want to try and avoid this. And the worst thing you can do is go into the Price is Right, where you have to choose one of two paths, neither one of which is something that's going to have a fruitful ending or have a positive ending. And, you know, typically once you get to the point where you have to make a choice, you're going to take the lesser of two evils. And that's typically what happens. And that's something to be avoided at all costs if you can. So the whole issue of having a proper risk management protocol, and this is very, you know, common in a lot of areas outside of the health professions. It's a real common business concept, as is regulatory compliance. As you know, anybody that's in the financial industries and financial services knows that regulatory compliance and risk management is one of the key things that they undertake and have to be in compliance with all the time. Yet in dentistry, it's misunderstood. You know, you want to maintain the fact that you can keep yourself in operation at all times, that, you know, you maintain some kind of ethical base, that you're going to best practices. So you practice dentistry in a manner that patient safety is one of the prime motivators, and that you have some kind of methodology that you evidence the fact that you're complying with the regulations and any of the statutes that we are really party to. And if we take a look, and this by no means is a comprehensive list of the regulators that we have to basically be in compliance with and have the ability to govern us. When we look at this, there's more than this, but these are the main ones. Obviously, the governments at all level, including municipal, you know, X-ray safety through HARP, and which is now under the Ministry of Health and Long-Term Care, the RCDSO, which is our prime regulator. The one that's becoming more and more prominent is the Office of the Independent Privacy Commissioner, and we can talk about that in a little bit, or if there's questions, I'll answer them. And by the way, the questions, if you pose them, please don't make them case specific to something you've encountered. It's probably more helpful that we keep them of a general nature. And one thing that's come in as of late, starting before COVID and through COVID, was the inspections through the local boards of health. And they have the ability to disrupt your practice. They can actually shut you down if you're not compliant with IPAC. And we've seen a lot of that, and I'm sure a lot of you have heard rumblings through the community of dental practices that have had deficiencies in IPAC and or might have been shut down. And it can be devastating, and oftentimes it's published in local newspapers, and the loss of reputational damage at that point is really something that's significant. So if we look at this, the main thing that you want to look at as well is, and we've had this tension in dentistry, is that there's a bigger sense of activism of the third-party reimbursers that exist. The insurance companies have greater scrutiny on claim submission, looking for validation and verification of treatments that were rendered, and also that they were indicated and then ultimately performed. Government reimbursers are a separate issue. They're really not to be messed with. You don't want to have any kind of misrepresentation in your billing. Any of you who do anything in a hospital, the issue of billing OHIP for services is very difficult if you get offside. And there's an act, I think it's a Future of Medicine act that governs that. And it becomes very difficult if you're offside there, and they will claw back money. And the big issue that happened through COVID that we saw is we have regulated healthcare professionals in a lot of our practices in the way of dental hygienists. Their guidance documents and their standards were decidedly divergent from ours during COVID, and that became acute, and it created a lot of tension within the community. And dentists had a hard time dealing with staff and having compliance for both CDHO and RCDSO, especially when they were divergent over the use of N95 masks, for example, fallow times for aerosol generating procedures. These are all things that kind of show that these things are difficult. So the whole thing we want to get a good look at, and I'd like you to understand tonight, is that regulatory compliance really is an essential part of what we do in dentistry. If I had my way, over the threshold of both dental schools in Ontario, it'd be a sign you are entering a place where you will become a regulated healthcare professional. And it seems to be that's one of the things that's not understood, that we at all times are regulated. We're regulated in many different dimensions. And as such, we have an expectation that we're going to comply. And I'll walk you through this during the course of tonight's presentation. And you not only have to take steps to comply, but you have to have evidence that you've done this. And for example, if you look at IPAC, for example, IPAC is really administered through the local boards of health and the RCDSO. If you get an IPAC inspection through a board of health where you're deficient, they have an obligation to report to the RCDSO. The RCDSO will wait for the report. They'll all look for some evidence of compliance and having a manual and having an IPAC officer. And this is all laid out in the guidelines that are available. So the thing that we always fight, and this is one of the problems that we have in dentistry, and dentistry is not exactly an effective model for the delivery of healthcare services, because we represent everything that there is in a healthcare facility. We provide the treatment, and we've created the environment where the treatment is performed. In the hospital, for example, you have a hierarchy that looks after infection control, one that looks after workplace safety. You have people that have other compliances with the Ontario Hospitals Act, making sure that physicians have privileging, there's meetings and all these other things. And we don't have that. And so what happens with us is we wind up in this loop where there's an action, we have a reaction, we make a decision, but we are really not very well equipped to deal with this. And that's where this starts to fall apart, because what's happened lately with the proliferation of social media and chat groups and WhatsApp groups, as opposed to getting real advice, dentists talk to each other. And that's like putting the inmates in an insane asylum in charge of the administration. I hate to say that, and I am at liberty to do this because I'm a dentist still in practice. Most dentists that are on these groups have no experience. They're not subject matter experts in a lot of these areas, and they tend to get the information wrong. And how do I know that? Because they wind up on my desk. I find out where they got the information, and typically they got it from their friends, and that tends to be a bad source. So let's look at what we're going to try and do tonight. We're going to look at informed consent, which is something that comes up pretty well in every case that I see that's before the college. Record keeping requirements, that's ditto to number one. They come up with issues, and I'll give you a couple of excerpts of what's in the complaint letters these days. I think it's important to spend a few minutes on electronic record keeping because it's an extension of the above. Record transfer, which is also misunderstood. Patient dismissal with when, why, and what. And then looking at electronic communication, because again, this is becoming a bigger part of what we do. So let's look at informed consent. And informed consent is, tends to be complicated. We have an obligation that we have to make a diagnosis and then come up with a plan for the patient. And not only do we have to come up with a plan, but we have to provide the alternatives where any exist, and also what the option is of not performing treatment, and ultimately look at the risk benefit, the outcomes, what's involved, and also the costs of each. So, and it gets complicated. So what is it all about? Here we go. So we've got a poll question. Okay, so it looks like we have 36 people that answered it. The correct answer is false. So informed consent, the pre-printed form, which I suggest that you have for certain procedures, is just evidence of a discussion. The informed consent is more of a discussion than it is of a form. The form helps fortify the documentation of the discussion. And so this is one of the most, you can see here that it's 8119. It's one of the commonly misunderstood parts of consent. So let's, you can see that. So we'll get back to the presentation. So we'll go through why you need it and how is it obtained and where do we get it from? Those are the real big areas here. So let's look at this. So it's a way that we basically tell the patient what they need to have done, and it's a process and dialogue and not just a form. So this is where it falls apart. One of the things I'd like you to take away tonight from the presentation is that dentistry has controlled acts under the Dentistry Act. One of the least understood controlled acts, and it's about what you can do beneath the dermis, what you can do in the oral cavity. But the most important one in the area of the controlled acts is that dentists are the only ones allowed to communicate a diagnosis, not your staff. Communication of a diagnosis is a controlled act. So that means that, you can't, my assistant will be in to tell you what needs to be done in a moment. No, bad idea. That's going to get you into trouble. The management consultants will tell you to do this. They don't know what they're talking about. This is all the dentist having to discuss this with the patient. So by extension, if you are communicating a diagnosis and then formulating a treatment plan, then you have to obtain consent personally from the patient. You can have someone there to help you document it, but you can't delegate this to your staff or your treatment coordinators. That's a bad idea. That's offside. That can get you in trouble, even to the point of it being an act of misconduct because it's inappropriate delegation of a controlled act to an auxiliary that can't perform it. So that's one of the things I'd like you to take away tonight, because that will change how you go about getting consent. So the other part is that the patient has to be educated enough where they can make a decision based on information that's true and accurate, and they have autonomy. And this is what's called shared decision-making. And this comes up a lot. And I can tell you as an endodontist, I hear this all the time. Patient comes in, they had endo done 10 years ago. There's a 6mm pocket on the distal of a molar. It's a bad looking endo. There's a post in the canal. They want to keep their tooth. The likelihood is that the tooth's fractured. You tell them, look, this isn't a good idea. It's not going to work. You're better off to take the tooth out, see somebody about possibly replacing it with an implant. They go, but doctor, I don't want to lose my tooth. I don't care. I'll sign whatever form you want. And I want to proceed with treatment. Technically, you may think on the surface you can do that, but if you know better, patients cannot consent around the standard of care. So if the standard of care is that they've got a 6mm or 9mm pocket and they want to keep their tooth, that you basically say, no, I don't want to do that. And they say, but I really want you to. The next step is send them for another opinion or refer them to a specialist. Or if you're a specialist, send them to somewhere else for another opinion. You cannot consent around what the right thing to do is. Consent is based on a high moral standard and a high clinical standard, and that just doesn't cut the mustard. So it's an important thing to get, because in the process of somebody reviewing the treatment that you rendered, you are going to be judged as much on two things, on informed consent and record keeping, as you are on your clinical standards. Now, if your informed consent is bad and your record keeping is bad, the likelihood is, if there's a college complaint, you will wind up having to take a course. If you don't have consent, it's considered an assault or a battery under the terms of the law or in the courts. And so it's going to create a very, very big problem for you. And both in civil litigation and in regulatory proceedings with the college, consent's a big part of it, as is record keeping. So it's something that has to be done. And it's under, and this is all in the regulations and in the code of ethics. And there's a Healthcare Consent Act that speaks to this directly, which outlines what you really need to do and the steps you need to take. And to be blunt, the good news about getting informed consent is this is a way that you can actually establish a proper working relationship with your patients, so that you develop that trust, they understand what you're going to do, they understand what's going to have the impact that treatment's going to have, the different options, what no treatment is going to have. Now, getting back to the use of auxiliaries, they can be there to help you document. So the use of a treatment coordinator is not to get a consent and not to tell the patient what they need to have done. You need to go over the pre-treatment plan with the patient yourself to get proper consent. I just had 2 complaint files that came in on decisions where that wasn't the case, and they both got courses and one got a caution. So the college is taking a very strict view on this, as they should. The treatment coordinator is great at arranging the treatment, making the financial arrangements, separate issue. And now in the new world, fees are a big part of the consent process, which I'll mention in just a moment. So you can take this is directly from a college decisions, and you can read this for a moment, that even though some of these issues are not raised by the complainant in the complaint, the committees tend to look at this because it's considered an integral and fundamental part of practicing dentistry. So it's something that you need to really get your head around. And you need it for every patient that you're going to treat. And the patient has to be competent to do this. If not, their guardian has to. And it has to happen before the treatment starts. And if there's changes, most commonly, go in, a cusp breaks when you're doing a restoration, file separates when you're doing an endo, root tip breaks off when you're doing an extraction. At that point, the prognosis changes and consent has to be obtained once again. You can't just sit there and bury it, because when the prognosis changes, part of the consent process is based on what the prognosis is for the treatment. And certainly if you fracture an instrument in a tooth and it can't be retrieved, then the prognosis is less. And the patient needs to know that. They also need to have consent as to how to proceed, whether it's patient referral to a specialist or whether you're going to attempt to retrieve it, which I don't suggest you do. But at that point, you have to get it again. And things like cosmetic dentistry, aesthetic restorations, there is a higher bar for consent because those are not based on any biologic need. Aesthetic deficiencies is not a disease, as some people may think it is, but you have to be very careful with this because you'll be held to a higher standard. So it has to be related to the treatment. The patient has to be doing this voluntarily without any misrepresentation of what the treatments are, the alternatives are, and it has to be informed by proper information. And there's another aspect to this that's also not often understood, and that is that of duress. It can't be done so that the patient is rushed into thinking that they have to do something in the immediate term, because that doesn't work either. Because if they feel that it's under duress and they make that argument, typically the consent process is going to get thrown out the window and they'll make the argument that they didn't have consent. So again, it's a risk-benefit analysis and discussion, alternative treatments, consequences of not having treatment done, and now, very importantly, what are the costs of the treatment differentials, and likely outcomes of success, and any further costs that may be incurred. So the main thing here is that you have to look at the diagnostics, make sure you have adequate diagnostics to do this. The patient has to understand what's going on. They have to have time for the patient to consider their treatment options and whether they want to go ahead, which is why that box is in the middle, because that's central to this. And it has to be charted so that there is evidence of the discussion, a form is helpful, and the notes to the discussion have to be at the time that this took place. And also they have the right to withdraw their consent at any time as well. And that's something that you really need to have front and center. And usually, and these go wrong, and it always gets argued that there's no consent, that they were not advised appropriately, the dentist's skills in the area were misrepresented, the prognosis wasn't good, they didn't have enough time to understand, they didn't understand the fees, or they had an untoward reaction and they didn't know this could happen. The question comes up if you do general anesthesia or IV sedation, is death a likely outcome of sedation? You can have that argument all night. So a lot of the anesthetists say yes, and it's in the consent process. But really, the outcomes of things not working, it also has to be realistic. Also, when you give an inferior alveolar nerve block, there is a possibility, although it's about 1 in 4 or 500,000, that they may get paresthesia or dysesthesia, and that should be disclosed at some point as well. So again, it's not a signature, it's not a one-time event, it's an ongoing process, and it's different for everybody that walks in to your office. And again, you can't rush this, and you can't consent around the standard of care. And even though all this is done properly, you still run the risk of the patient not being satisfied. So this is material that's off the RCDSO website. Brian Gover is a retired Superior Court, or I think Appeals Court Justice in Ontario. He wrote this for the college a number of years ago. You should go on the college website and read these documents. It's very helpful. The next area to look at is record keeping. Again, the college has this on their website. I'd suggest you read these guidelines. This is directly from the letter that dentists receive when they have a complaint. The complaint committee is going to look at the dentist's record quality. They look at this as basically a litmus test of the diligence that they have in providing proper treatment and meeting the standard of care. And they may make suggestions or actually order a course in many cases for you to improve your record keeping. And again, part of the trust that we have to have with the public is that we have to uphold the standards of the profession, and the record keeping and failure to keep the records is an act of misconduct. And as such, it's part of the trust that we have, and it's an obligation that we have. So if we look at what constitutes a record, it's any notation of information that's given to the patient, whether it's by telephone, by electronic media, written, verbal, and we have to keep notes of this. We have to have contemporaneous notes. We have to note each interaction with the patients under the guidelines, and it has to be noted. And there's certain things that are common to all record keeping, and this is what somebody gets when they get a complaint. And if you take a quick look at this, there's, the intake forms, the medical history form. The most important thing that people don't understand they have to have is an up-to-date odonogram. That's very important. If I were you in general practice, I'd buy myself an intraoral camera if I don't already have one, and I take intraoral photos. Intraoral camera is not your iPhone. It's an actual camera that's hooked into your dental office management system. You don't want personal health information on your iPhone or Android, whatever you use, because that fortifies what the condition of the mouth is, especially if you're doing certain restorations and then ultimately get an insurance inquiry. It helps you out. But you can see this is a very comprehensive list here. And, again, this is all available on the RCDSO website. And, it's related to, you need to have a dental history. You can use some short forms and acronyms as long as they're consistent and there's kind of a key for what they mean. And for example, when you look at radiographs, if you take radiographs, you have to have a note in your chart that they were reviewed. Even if everything in the radiographs is within normal limits, you still need to have a notation WNL or within normal limits, reviewed radiographs within normal limits, or reviewed radiographs incipient carries on. And then you have to come up with a diagnosis and treatment plan because that's needed for consent. So we're going to go backwards because that's one of the things that you have to have. And in the comprehensive examination, you need to have an odontogram. The other thing you should do is take a look at the preamble of the ODA fee guide if you're an Ontario dentist, and take a look at what the requirement is for a comprehensive clinical examination. Oh, my dog wants to talk because he's not getting any attention here. And there you'll see that there's certain requirements for meeting the standard of having performed a comprehensive clinical examination. And if you don't find those, I'm just going to turn my video off and get rid of my dog for a moment. If you don't do that, when they come and do an audit, they may deny the charge that you didn't do the complete clinical examination. Be good boy. Anyways, that's something that's a requirement. And again, it's important that you look at the fee guide because in order to get paid properly for procedures, you have to meet all the criteria. And if you get an insurance audit and you don't have radiographs, for example, indicating decay, or you don't have clinical photos or a good odontogram, they may deny claims. And so again, you need to have adequate diagnostics, and then have a diagnosis and treatment plan to follow. And this all speaks to having why you're doing the treatment. And if you don't have that, then you may wind up having a problem. Okay, question 2. This is a little bit in advance, but record transfer requires a signed release. Okay, so the answer is when it's going to a third party that's not the patient, the answer is true. If it's just going to the patient, at which point it's really not a record transfer because we are custodians of our patients' records, then it's false. But this is for the most part true, and we'll talk about that probably in the next 10 minutes or so. So again, you want to take a look at when you're doing your diagnostics and making your treatment plan up, even if there's suggestions for referral, that it's in the treatment plan, because oftentimes when things go sideways, the lack of referral is one of the things that comes up in complaints decisions, and you always have to have some kind of notation of the consent, and progress notes really should be detailed. Things like periodically, there should be a note in there that you've reviewed the medical history, what anesthetic you gave, where you gave it, how much, what materials you used for restorations. All these things are very important. Exit notes, that's something that's becoming more and more popular. The reasons that the patient is leaving your practice or doesn't want to have anything done. If they come in for recall and you want to take bite wings and they refuse, you really need to note that they refused bite wings. All these things need to be in there, and the more detail, the better this is. And let's spend a couple of minutes, and it's not a long discussion here, but it's something that you really need. It's another thing I'd like you, this is number 2, that's the takeaway from tonight's presentation. You really need to look at the electronics record management guidelines. They're being reviewed right now by the college again to bring it up to date because of the amount of electronic data that's being housed in dental offices. The electronic data that we house comes under the auspices of the RCDSO and the Office of the Independent Privacy Commissioner because it's health-related information. And as such, we have an obligation to protect the personal health information, or the PHI. The big thing in the guideline is backup, verification, redundancy, and data security. What do I mean by that? There's an obligation to back up your data, and pretty well everybody backs up their data. However, what they don't do, and if you read the guideline, it's a requirement, is they don't verify that the backup has taken place. So not only do you have to make sure that you have a backup, but you have to know where the backup is and that it's backed up the data somewhere that's not in your office, preferably, or possibly in your office and somewhere else. The step that I can tell you is taken by less than 10% of the offices in Ontario is the verification that you have the backup that then can be used to restore the data. So what's very important, and this is the takeaway, is when you go to your office on Monday, talk to your IT people, whoever manages your network, find out if they can take one of your data backups and on a third-party computer, open up the data so that you can be back in business should you have a crash. The reason this is important, and I've seen this many times, is that there's some kind of incident in an office, the data somehow gets corrupted, or you could have a hack or ransomware, cybersecurity issues. And as such, you can't back it up you can't recreate it from a backup, and it's basically useless to you. So that's something that you need to look at. And also you need redundancy. You need backup in more than one place. The other thing is you have to have security over your data so that third parties can't get in and use it. One of the easiest ways of people to hack into your office, if they choose to, is through a wireless network. You should talk to your IT people that if you have a wireless network for your patients to use when they're in the office or your staff, that this is not attached to the router that goes into the main system that manages your network in the office, that it's a separate system. So that's an important thing for everybody to kind of get their head around. So that's it for electronic data. It's not a big discussion. It's just basically a manifest of what goes on. And this includes, if you have paper records and a dental practice management computer system and have digital radiographs, then and you're running two systems, partially paper, partially electronic, whatever's electronic falls under that, whether it's fully paperless or not. Whatever's captured really needs to fall under that. Record transfer. So the patients themselves can request a copy of the record, and they can request whatever they want. They want the entirety of the record, the dates they want it from, what have you. The request does not have to be in writing. They can phone the office and say, I would like to have a copy of my record. Now, when they do that, you can send the copy of the record to them personally, either with a physical copy or electronic copy, properly securitized because it has personal health information. It's better if it's in writing. Again, the RCDSO has a release and transfer of patient record advisory, which I suggest you read. Basically, the patient is the one that has the record. We keep it on their behalf. We're custodians. And as mentioned about 2 or 3 minutes ago, this is governed both by the RCDSO and the Office of the Independent Privacy Commissioner. The rules for the Privacy Commissioner are a little bit different. It's something where the patient can request not only the record under the Privacy Commissioner, but can request a correction to the record. I've seen this happen more times than I'd like to admit to. It's happened in my practice a few times where the patient wanted to make sure that they indicated that they were involved in a traumatic injury. They wanted to review their record to make sure they said that to me. In 2 cases, they didn't, and I had to correct the record to indicate that they said that they were in a traumatic injury after the fact, and that was for their own insurance purposes. Generally, under the Dentistry Act, it's a professional responsibility to transfer the record in a timely manner, and you have to do this whether they owe you money or not. And whether you should charge for this or not, I would say you don't charge for this, especially in today's electronic world, because you can scan everything and send it to them by email through a password protected PDF. But if you hold it back because of an account balance and they file a complaint to the college, guess what's going to happen? You're going to wind up having to take a course because the college doesn't care if they owe you money. The patient owns the record. It has nothing to do with their financial relationship with you. And the record request can be innocent. They're moving somewhere else. They want to go to a different office. It may be that they want somebody to review their file to see if the treatment they received was appropriate. Oftentimes, insurance companies request records, and you'll get that in writing from them. It could be that they want the record because they want a lawyer to look at the file, or they're contemplating filing a complaint. And as I mentioned previously, they don't want to request a correction under HIPAA. So if you can send it directly to the patient. If it's going to a third party, it needs to have a release signed by the patient, and that's fairly straightforward. It can be another dental office. It can be a law firm, paralegal, or any other agency that's looking for this. It should take place within 5 to 10 business days, and don't charge a fee for this because it's not really appropriate. It's just going to create problems. You can do it if you want to do it on a USB drive or CD-ROM if you feel like doing it, if you're still in the old ages of technology. I send all of mine through a password-protected PDF. It's very easy to do this. All you have to do is Google password protect PDF and it comes up on the Adobe site. It comes under security. It's very easy to do, and you don't send the password in the same email with the password protected PDF. You pick up in the phone and call the recipient, or you send in a separate email. So let's look at item 5, patient dismissal. Again, a very misunderstood concept. It's the act of basically telling somebody you don't want to treat them anymore. It's something that you have to consider very carefully. There's a lot of misconceptions here. It happens de facto, meaning it's not implied, but it happens if somebody initiates a lawsuit or files a complaint. At that point, they have basically said, you know what, I don't trust you anymore. The relationship is broken on their part between them to you, and they're advising you of this by either serving you or with documents or filing a complaint to the college, and you get that personal and confidential email through their secure site, and you no longer have to see them. There's an advisory on maintaining a dentist-patient relationship properly that you should read as well. It's an act of misconduct if you don't do this reasonably, and I've seen this happen where dentists just, get upset with a patient, questioning what they did, especially if, for example, they put in a bridge and a week later they need an endo on one of the abutments. They'll come in, they'll be upset because they haven't slept for 2 nights, and they'll say, you know what, you're the worst dentist I've ever seen. I don't like what you did. This is so upsetting that I was up for 2 nights. And they'll go, my God, they lost my trust, blah, 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 blah. Well, they're actually upset because, they had something happen. They may or may not have been advised that they may have to have an endo after you put a bridge in or something like that. It's something you have to weigh, that you don't want to dismiss them at that point. But typically this happens because, the patients request that they want to go somewhere else, or they don't want to see you anymore. You need to arrange emergency service if you do dismiss them, and you have to give them a reasonable chance to do this and see them for emergencies until they find another dentist. But what you really need to do, and this is one of the big things that I've written about in ODA, is when bad things happen, you need to look at, why did it happen? Is this a result of something we did? Is this just one of those things where, we didn't discuss things fully? What is going on? Okay, so this is a good question at this point. We're back on track here. Workplace violence and harassment policies are something that you should have in place. If you don't, that's something else you're going to take home and do. So does it come into play in dismissing a patient? Okay, so the correct answer is true. It does come into play in dismissing a patient, and it's probably the prime reason why you would want to dismiss a patient and when you would dismiss a patient. If somebody comes in that's intoxicated, somebody comes in and is belligerent, somebody does a violent or aggressive act, grabs the chart out of your hygienist's hand, makes a sexually inappropriate remark to you or one of the staff members, that is something that you have to take seriously under the workplace violence and harassment policy. If you don't have one, you need one written. Somebody has to be your officer on this, and there has to be a mechanism in your office for these things to get heard and then mitigated. And you have to have a meeting with your staff, and you have to do something about it. So if somebody does something inappropriate, that is one of the main reasons why you would want to dismiss a patient. If it's something clinical or they're upset about what happened in an outcome, you have to turn it from boil to simmer, because if not, I can tell you, if you have an upset patient, I would bet the farm that they're going to file a complaint or sue you if you kick them out of the office. If you do treatment and something happens after and they're not satisfied that you're there to stand behind it or refund them their money or do something to satisfy them, then they are going to wind up filing a complaint or suing you. And so that is not the point at which you do this. Once they're satisfied and the treatment's completed, or you find that it's more difficult than you have thought before you undertook the treatment, at that point, you don't dismiss the patient. You refer them to somebody who may have a better skill set or more adept at this. If it's a crown and bridge case, get them to a prosthodontist. If it's endodontic treatment, get it to an endodontist, orthodontist, etc. But don't dismiss them just because they get upset because what you were doing isn't working out or you ran into a problem. Not a good idea. So you have to look at this. This is a learning experience. If they're upset, why are they upset? Was it a communication problem? Was it a treatment problem? Was it a treatment deficiency? Did something happen where you left them hanging in the room for 20 minutes to go talk to your stockbroker? I mean, these things happen, but referral is a better option than dismissal. Dismissal is a very aggressive act. And as I said, one of the big things that you have to do is you have to tell them why you're going to dismiss them. Under workplace violence and harassment, it's very easy because you have an obligation, and a very positive one, to have a safe workplace for your staff. So as a result, that's one of the areas where you really have to look at this and say, yes, it's not something I want to have. And the letter has to outline what further treatment needs to be done, what happens if they don't get it done, and give them a way that they can actually find somewhere to get this mitigated and get further treatment. So the last subject tonight, and then I have a little bit of potpourri after, is the issue of text and email, and it's becoming very misunderstood. It's actually become a lot more dangerous than any of us thought it would because of the basic and common use of text and email in our personal lives. And I'm going to walk you through this, and if you have any questions, well, we're going to take them at the end. The basic rule between a dentist and a patient is no texting. Worst thing you can do is text your patients. If all the lawyers that do legal panel work for the CDPA, if they could, they would go to the dentist's office, take a hammer, break the phone so they couldn't text their patients. Also, the same goes for your staff. You don't want to text your staff either. And text is all of the ways you communicate digitally, whether it's SMS and text, WhatsApp, anything on Instagram, X, Facebook, Snapchat, whatever. Lose it. Do not text your patients. Whether they want to talk to you by text or not, you have to maintain some distance in a professional relationship, and it really isn't going to end well if you keep texting them. Texting your staff is the same thing. People text you when they're upset. They don't text you and say, my God, I had the best day in the dental office today. They're going to tell you that they had something bad happen, or I can't believe that somebody was rude to them in the office and you didn't do anything about it, and you're not managing your staff. And, if you text them, your staff, and say, you know what, I can't believe how rude you were. You really upset me today. You're going to wind up having a staff member that thinks that you're dismissing them. They're going to make a case that you created a hostile work environment through your texting, and they're going to wind up suing you and claiming damages from you. And that's documentary evidence that you did that. Bad idea. Texting is difficult to archive. It has security and privacy issues. Personal health information should never be transmitted through text. It is a bad idea. And it's one of the worst methods of communication because it eliminates distance. And the whole thing with professionalism is distance between us and our patients, and familiarity with our patients is an enemy. You can say the wrong thing. You can wind up crossing a boundary inadvertently. You can send them a joke that they find offensive, which can result in you getting a complaint to the college and having to take a boundaries course. You don't want to do that. Your friends can be your patients, but your patients can't be your friends. And you have to maintain that. And you really want to stay away from texting. It leads to very, very difficult problems. And if you do have a text from a patient that you respond to, you have to archive that in the chart. It goes back to the record keeping, and that's a requirement. And people will tell me, well, that's not a big deal. Take a screenshot, or there's third-party apps to do this. No texting. It's not, I don't get text. Well, you don't get text from anybody that's performing medical treatment on you. You don't get text from lawyers. This is a bad medium, and it's to be avoidable. The only reasonable use is an automated appointment reminder system, but there's a caveat to there as well, because any data that you give these third-party applications, you have to check where the data is resident. If it's resident outside of Ontario, you can't use them because that's transferring PHI outside of Ontario, which will put you in violation with the Office of the Independent Privacy Commissioner, which I can tell you right now is not a friendly organization towards dentists. So again, no texting. And if you want to ask me about that, I'll be more than happy to talk about it, but there really isn't much to talk about. Email usage. There's 3 ways that email gets used. One is a random inquiry by a patient that finds you on a website. The other one is some communication between office. And the third one that gets used, which is really the most inappropriate, is anything that has personal health information or treatment advice in the email. It just can't happen. The emails, and the big thing that does not get managed well in dental practice, and it can turn around and bite you 100 times, is the info@LionelLenkinski.com or Lionellenkinski.com, which is your general office intake email. That has to be overseen by somebody that's a dentist, the owner of the practice, probably. You can't have your office staff manage that without you having any oversight, because anything that goes back and forth between you and a patient is part of your communication with the patient. You are the one responsible, and you're going to be held accountable for it. You can't give specific advice over email. The best thing to do is ask for a time that you can have a discussion and then document the discussion. And it's email back and forth is appropriate for general information. Things like, do you perform implants? Yes, we do. You know, how do I become a patient in your office? You send them the link if you have an online form, or you send them a PDF with a medical history form or intake form. That's fine. But getting beyond that, not a good idea. Because if it comes from your office, it comes from you. And you can't defend yourself by saying, you know, my receptionist was out of line. No, you have a positive obligation to oversee them and monitor what they do. So this is something that is very commonly missed, and you really need to spend some time on this. It's a very important part. And you have to have an internal procedure as to what happens with ingoing and outgoing correspondence. One of the big things, if a patient requests their records, you know, who does that go to? Does that go to your receptionist, or does that go to you? If I may be so bold, you're the one that really needs to oversee this. So if some record request comes in, whether it's from a patient or a third party, that should go to your desk. That should be notified to you. You need to oversee what gets sent out, because if not, if it's not done appropriately, you're the one that's going to be held accountable. And the last thing you want to do is, if something is upsetting you, is respond to the email. And you can't delegate the treatment responses to somebody in your office. They really have to be handled by you personally. You have to be very careful how you do this. You don't want to be giving treatment advice by email. You know, if somebody says, is it normal that my tooth is sore? You can say yes, but I'd prefer to talk to you if you have time. You're always better off to pick up the phone. Again, you have to really establish who's going to monitor the inbox, how it's going to respond, any concerns other than, can you please resubmit my insurance form? I didn't get reimbursed. I have some issues, questions on the treatment plan. Those things have to come to us, and we have to respond to them. And you have to be very careful, because if you don't respond appropriately, they can complain about this, they can sue you. There's all sorts of things that can happen. Fee inquiries, scope of practice, post-treatment problems and billings, those things can be handled effectively. Post-treatment problems, you don't want to give advice or say you think you need a prescription. That if you think it's beyond somebody saying, you know, I lost my post-op instructions. Is the tooth still supposed to be sore after I did an endo? It's been 2 days. Can be normal. Is Advil working? Great. But it's better that you actually speak to them. The problem you have is if somebody is not a patient of record, and this is new people fishing to see what you do, there's a limit to what you can do, because you don't have consent to transmit personal health information, and you need permission and consent to do that. So if they're not a patient of record, it's, do you do implants? Yes. Do you do endo? Yes. Do you do sedation? I do nitrous oxide. That's fine. You don't want to be sending fee estimates out without having seen the patient, because you're going to be held to them. And it's not a good idea, and it's not entirely appropriate. But anything that has medical information needs to have a consent under your privacy policy, under FIPA, and under the Office of the Independent Privacy Commission, because all that stuff is protected. And if it comes from an existing patient, at some point they will have signed a consent, hopefully, because you should have that in place. You need to have a privacy policy in place which deals with this. Some of the information is available at the IPC's office online. If not, you can contact me. I can direct you to it. And without express consent, you can't divulge anything. And across email, even with express consent, personal health information has to be protected. Usually with a password protected PDF is sufficient. A lot of people use end-to-end encryption in email providers like BrightSquid or CDA Secure Send, but I prefer to use password protected PDFs because it's easier. And it's easy enough to do. You don't want to start creating, the door number 2 situation, like let's make a deal, that they request something and then you wind up disclosing it to a third party or it's not properly protected. And if they want their information sent to them, just let them know who and when it will be coming from and which email address so that they get a heads up. And again, try to secure the information. And one of the things that happens is, we try to look at a lot of cognitive behaviors, or I do. I teach a course on bias in clinical decision-making. That was a CAT 1 course given at ODA a couple of years ago. And one of the things I delved into was the whole behavioral psychology aspects, why we wind up with this. One of the big things is that naive realism is we talk to ourselves too much. Dentistry is typically practiced in isolation. Often it's either solo practitioners or 1 or 2 or 3 dentists practicing together. It's very insular. We tend to talk in echo chambers of people that are like-minded, so we don't check our thinking, and we get into these bad habits. We do things that are easy and they're hard to break. And right now, one of the biggest traps is social media, because people get on chat groups, they exchange ideas. I can tell you, predominantly, they're not based on any kind of reality, especially when it comes to regulatory problems. It's amazing what they say in terms of record keeping, in terms of other things. You really need to find some true experts and mentors and measure them and look at the literature. One of the big things that people have stopped doing is reading the literature. There's bodies of literature out there on success rates, outcomes, procedures that we really need to get more into. Talking to people on these groups is great. Doing a Google search is great, but the problem with Google is that you're going to get a 2 or 3 line response where you really need to look at the entirety of the body of work. It's very important. It's becoming a big problem in dentistry, less so in medicine, where it's more ingrained into their training. The other thing that we always have to look at is, not doing anything where there's harm involved. And this is something that, the word let's try this is something that really should not be in dental practice. So the feedback loop is a little more complicated, that the one that we really should have operationally, which is, and the action has a reaction, and then we notice what happens, and then we look at the outcome, and then we change what we do, whether it's we get more training, whether we revise how we do things. This is very important to look at, because this is how we change. This is how we get better. This is how we practice to a higher standard in what we do. And it's something that we really need to take a look at. So I'm going to conclude with a couple of things about how we're regulated. Under the RCDSO, it operates under the RHPA, the Regulated Health Professions Act, and the HPPC, which defines how the college operates in meeting out the Dentistry Act. And in the Dentistry Act, there's 61 acts of professional misconduct. If I asked everybody if they've ever read this, they'll say no. It's very important because it lays out a lot of different things. One of the things that's laid out in there, by the way, is taking fees in advance of treatment. A lot of people try to do this unless you satisfy its paragraph 4 in the Dentistry Act, which lays this out specifically, that you have to have a written arrangement and then a procedure whereby if the treatment doesn't go ahead fully, that the patients get reimbursed. You have to have written arrangements to do this. And then I always hear the same squawking, which is, well, lawyers take money and trust in advance. Well, we're not lawyers, we're dentists. Dentistry is fees for service. It's something where we have to give the patient an itemized accounting of what we've done, and we can't take payment in advance. We get paid for what we do. So if you take a look at some of the acts of misconduct, one of the most common ones that people get clipped on is number 11, which is contravening the standard of anesthesia and conscious sedation. 14 is when they discontinue treatment before it's finished, and they don't provide the treatment in the treatment plan. And this happens for a lot of reasons, and they don't care if you're getting paid or not. If somebody started to get a crown done in your office and they basically tell you they're not going to pay for it, there's a question as to whether you need to complete it or not. Oftentimes, you're better off completing it than exposing yourself to the fact that you could be falling short under Article 16. And one of the things that happens, and it's very common again, is dentists not collecting the copay. And there's no excuse for this because that's an act of misconduct. Again, this is something I tell everybody to do. If you haven't, look on the RCDSO website. They have all sorts of guidelines and standards and advisories. It's one of the few regulators around that actually has this published. It's a roadmap. I recently gave a talk to the Canadian Association of Dental Consultants. The out of Ontario consultants, when I put the slide up, said, thanks for doing this. We send all of our members to look at the RCDSO website because it's got so much information. And it's got information that's cross-sectional on almost everything. It'll give you a lot of information. It's required reading. Now, when they look at complaints, what they look at is a risk assessment framework. And this is how they decide what actions they're going to take. And if you take a look at this, you know, most of them wind up with no action, but more and more now are getting advice to member. And in the moderate risk category, they're getting a SCRP, which is a specified continuing education remedial program, and a caution, meaning that they're going to have to appear before a panel, and the panel's going to look at them and say, you did this wrong. You have to change what you did. You're going to take these courses, and we're going to monitor you. So if you're ever ordered a course by the RCDSO, monitoring is part of it. It's usually a up to 2 year process where you get monitored every 3 months and somebody reviews your practice. And that, again, if that ever happens to you where you have to take a course, you look at this and say, why did this happen? How did this happen? How do I stop this from happening again? It's not something you want to fight. If you fight it, you'll never improve and you won't get the feedback loop you're looking for. If you're a very bad person, you might get a referral to discipline or an interim order restricting your practice or suspending you from practice. It's usually in the high-risk cases. It's for repeats. Oftentimes, it's people that have billing irregularities. Typically, 3 out of 4 disciplines arise from people that are inappropriately billing third-party insurance plans. Often, it's not that they give you a lot of leeway if you're clinically deficient, and they'll limit your practice. Mostly, this is related to people that have behavioral issues. And the risk assessment is based on, does this complaint and the treatment rendered result in significant patient harm or minimal patient harm? Did they have anything in the other issues? Is the consent good? Or is the record keeping good? Is it a billing issue? But the most important thing that's coming out now is, did the dentist show insight into what they did and why this happened? So there's a lot of emphasis now on the behavioral aspect of us being reflective on, is this something that we can fix? And in the complaint response, the lawyers are very good at framing this, that the dentist understands why this happened and what happened here. If it includes some kind of dishonesty, you're going to be cooked. They look at prior decisions since 2010. Whether you're cooperating with the investigation and doing things in an appropriate manner, especially if there's a college investigation happening under Section 75, then that's a big issue. And again, they look at the risk assessment. How harmful is this behavior to the public? Because don't forget, the college is there to regulate to public trust. And they want to basically look at whether it's low, moderate, or greater risk in terms of public harm and the potential for harm and potential for this being a repeat problem by that practitioner. Typically, the decisions have no further action or advice to member, the SCRP. A lot of them now have cautions. Some of them have conditions and restrictions depending on what's going on. I've seen cases where the dentist has done 6 or 7 hours of continuous treatment on patients that are in their 70s that are medically compromised. They look at that as saying, you know, this is deficient because you're putting the patient at a certain degree of duress and risk. So be careful with that. They look at the duration of sedations. They need to be reasonable. Unless you're fully trained in anesthesia, you don't want to do anything before beyond a couple or 3 hours because it doesn't work. They can restrict your license or refer you to discipline. So basically, the reason I wind up doing this and the way I do it is I'm a consequentialist. I really believe that you know, we are accountable for what we do, and we have to gauge what we do based on the outcome, whether we do something or we don't do something. What's the outcome of doing it? What's the outcome of not doing it? And look at it that way. And, you know, if we take a look at other things, you know, what happens when they come in and have a complaint, they don't necessarily just restrict it to what they look at during the complaint. Sometimes other things are uncovered, and they're ad lib to do this. They can have a Section 75 investigation, which expands the investigation beyond the scope of the complaint because they find that there's reasonable and probable grounds that an act of misconduct might have taken place. And they can come in and even observe you in practice and watch your work. And a lot of these things go on the public register, whether it's if you take courses or if you have a caution, it'll be on the public register. Interim orders are on the public register. Deficiencies in your member authorization or facility permit for anesthesia will be on the public register, as will any deficiency in a CT scanner permit as well. And it'll go on right away. It comes on within a day or two of the report. And it's always updated. And referrals or allegations of professional misconduct are on, pending disciplines are on, incapacities are on, as are suspensions in effect. And also there's a section for illegal practitioners. And that's getting bigger and bigger. So if we take a look at this and briefly what happens if you do get a decision and you're unhappy or the patient is unhappy with the decision, they can appeal the decision to the Health Professions and Review Board, which is a lay body that sits above the complaints committee to look at the reasonableness of the investigation. They can confirm the decision of the college, or they can send it back for further consideration. Rarely do they rewrite the decision because, again, this is a lay panel. The committee, the ICRC, or the former complaints committee, is viewed as a panel of experts in dentistry. HPARB is a panel of experts in process. You can then appeal under judicial review to divisional court, where 3 judges look at the judicial review application. They are experts in law. They look for an egregious breach in law. And if you don't like that decision, you can seek leave to appeal to the Court of Appeal. And that's the next level. Now, complaints committee defenses can cost anywhere from $6,000 to $10,000. HPARB is probably 6 to 10. Divisional court judicial review applications about $50,000. Court of Appeal starts at the price of a luxury car at $100,000 typically for these things. And if we look at the advisories and standards that I told you to read, there's 6 standards. I think there may be 7 now, 7 guidelines and 12 advisories. Get a look at these. I'm going to close with this. You know, the big question, and Carlos Quinones and I do a workshop on dental ethics, and he goes, how are we going to talk about this? And I said, there was something in Forbes magazine many years ago that, you know, the question always comes up, should you teach ethics in business school and law school? And this guy wrote a great article that they should stop teaching ethics and start teaching federal sentencing guidelines, because it probably has more impact and will have a greater and broader reaching effect on people staying in a compliant zone. And I believe in that, because if you understand the consequences of what you do from a negative perspective, you're less likely to do it unless you have some kind of personality disorder, which I've seen as well, but that's a separate issue for another discussion. So I'm going to fast forward and hang on. And thank you for your attention tonight. That's how you get in touch with me. I'm easy to get a hold of. If you email me or call me, I'll get back to you. And I'm prepared to take any questions that you may have.
Awesome. Thank you so much, Dr. Lenkinski. I found that super informative for sure. Yeah, so we'll dive into those Q&A questions. I just want to remind the audience as well that if you have any more personal questions, I'm sure Dr. Lenkinski would be happy to answer those either at his email address or wherever he wants those directed to. But for the sake of these
I have a very active inbox.
For the sake of this presentation, we'll do the more general questions to start off.
Sure.
The first question is, hi, Dr. Lenkinski. How common are audits for dental insurance companies, from dental insurance companies?
Very. So, let me get back and let me get this back on here, so they can get the contact info.
Mhm.
They're very common and getting even more so. So if you take a look at one of the most fulsome and robust applications of AI and data mining, it's looking at insurance claim data. It's looking at medical records for trends. And there's a lot of companies out there that do this. The major insurers have very sophisticated fraud prevention departments and staff, and they will look at these things and they will find it. I mean, when I was talking to the Association of Dental Consultants, that's why I was there. I was actually in between the registrar of the RCDSO, then there was myself and Steve Minardo from my team, and then Leslie Redmond from Advisory Services at ODA. We all had the same message. The last thing you want to do is anything that you can't support with the diagnostics in your records. It's very common. They look at trends. They're going to look to see how you compare to the community standards. They're looking at how frequently you do certain examinations. What's your fee for examinations? Are you at the top end of all the variable codes? And it's getting more and more common. And this, again, is all based on your record keeping. You have to have evidence that the treatment was indeed necessary, and two, that it was properly provided. And, you know, we've seen more and more cost recoveries where they're looking for some amount of money to be reimbursed by the dentist and dental practice to the insurer for things they see that shouldn't have been billed. A common thing is unbundling of codes. Other thing is stacking of codes. I've seen dentists that have used regional block anesthesia codes when they've put local in for scaling, you know, just to bump up the fees. So if you're doing that kind of stuff, be careful. If you get an insurance request, answer it promptly. Most of them are innocent. If you find that they give you advice that you're not doing something properly, you do not want to be arguing with them. You want to take a look at this. Why did this happen? How did this happen? What was I doing that got their attention? And then change it. Because if you don't, they are going to come after you. And I've seen upwards of mid-six-figure cost recoveries over the course of my doing this for over 20 years.
Wow. Wow, it's certainly important to have that in the back of your mind for sure.
Yeah.
Next question.
Plus, word to the wise, if you go to a course and the person giving the course is going to give you the billing codes for the procedure, say thank you for lunch, go home, and forget everything that they told you. Because whatever they told you is going to be wrong.
Good advice for sure. The second question is the workplace harassment policy requirement specific to Ontario?
That I'm not sure, but I know that it is here.
Okay, and then next question is, what type of procedures do you suggest written informed consent?
Most everything. So you have implied consent to do a examination, verbal consent to take radiographs. In my office, we have a consent for minimal sedation, and consent for our core procedures. So definitely sedation, you need a separate consent form, and the documentation that's required under the guideline and standard that the college has. You want some kind of sedation record that's going to be used. Anything that's surgical, for sure you're going to need it. I would have one for crown and bridge, and I'd have an information sheet that you give patients about restorations. Things like you can expect sensitivity, B, the restoration has a lifespan of, all these things. You may not need written consent in a form. You'll need some kind of notation that you had a discussion based on an information sheet. But anything surgical, endo, extractions, implants, if you're doing periodontal surgery, perio, orthodontics for sure, because there can be relapse. You need to have something. And in a lot of these, you'll need to have financial terms as well.
Another question here is, what should I do when the patient does not want to pay? An example, just promised to pay and never showed up again.
Are you asking, should you send them to a collection agency? I would say no. Basically, if they have an outstanding account and they haven't shown up for treatment, they've dismissed themselves from your practice. I would just make a note not to rebook them. I wouldn't send them a letter of goodbye, because they'll find something wrong with what you did that they didn't pay you for.
Right. And then another question here is, when dismissing a patient under the harassment policy, is one required to provide the emergency coverage or to conclude active treatment?
No. At that point, it's different because it's a danger point. So at that point, you'll just tell them that they need to go to the dental emergency service or seek treatment elsewhere.
Just letting a little more questions pile in here and just filtering through.
So Mike, I have a question. Did everybody stay awake?
Well, I sure did. There's really a lot of parallels between your industry and the financial services industry, especially a lot of the same ethical and regulatory obligations.
It's all the same derivative.
Mm-hmm. Oh, yeah. Murray's awake. Suzanne's awake. That's good.
Good.
Awesome. Well, if there's no further questions, I can go ahead and wrap this up. Thanks everyone for joining us this evening. We hope you found this presentation very informative. Don't forget to go to tmfd.ca to register for our next upcoming Dental Academy webinar, so you don't miss these great presentations in the future and earn some free CE credits in the process. You can expect CE credits to be emailed within about 2 weeks following this webinar, no later than December the 6th. Thank you so much for joining us. Thank you, Dr. Lenkinski, for your time, and have a great night, everyone.
Thank you. Thanks again for including me.
Awesome. Take care, everyone.